You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
This is the Pain Pod.
You want to see pain? Look at these.
Welcome to the Pain Pod, the podcast for all things pain management. Hosted by the Pain Guy, Dr. Mark Garofoli. We'll be collaborating with numerous pain management experts, talking about substance usage disorders, the latest treatment modalities, and most important, focusing on the pain of our patients as leading providers of pain care. And now, here's our host, a man wanted in all 50 states, a suburban city-like mountain man,
Without the beard.
from the hills of West Virginia, and certified in weapons of mass destruction response. It's Dr. Mark Garofoli.
Welcome, everyone, to the Pain Pod. As we always say, come one, come all, welcome to the Pain Pod. So, on this episode here today, as you're listening, Pain Pod Nation, we're going to be going over NSAIDs. It's the age-old he said, she said, which NSAID already, and all of the information that comes along with such a short name of NSAIDs, non-steroidal anti-inflammatory drugs, NSAIDs. Much ado about much, actually. Lots of different options when it comes to NSAIDs, and we want to come in hot, of course, and leave you all with lots of perspectives, whether a patient, whether a clinician, whether anyone in our community anywhere, right? There's a lot to go over when we're talking about NSAIDs. There's prescription, there's OTC, there's, things that are available in other countries, there's different formulations, you name it. There's a lot going on when it comes to NSAIDs. Here, as Pain Guy here, what I want you to leave this conversation with is not an abundance of information on NSAIDs, but I want you to have your cake and eat it too. The next step, okay, all that information's great, hopefully, right? But now what? Which one? Which patient? Why? The big picture questions, right? It's really good to acknowledge that there's a lot going on when it comes to information on NSAIDs, but then we're left with, well, where do we begin? Right? As a patient, what should be selected even when you're standing in an analgesic aisle? As a clinician, we've got a lot of options overall, right? Within the overall diverse pain management treatment plan with everything, pharmacological, non-pharmacological, you name it. So let's sink our teeth into these things we're calling NSAIDs, okay? We're going to start in our hot tub time machine. We're going to go back with a little bit of history, okay? I'll be brief. Don't worry, folks. But we're going to start something around 400 BC. Kind of hard to see what the stone tablets said, but Hippocrates was said to use willow bark and the leaves to treat fever. It's said to have included salicylic acid, so it's natural. It had to be good, right? Sounds almost like a jelly or jam commercial, quite frankly. But in the big picture, there's thought to that. There, the original, the OG sources here being natural. So let's fast forward in our time machine here to the 1600s over in Germany. Man, so many pain medications come from Germany. What is in their drinking water? I know there's chocolate, I know there's vehicles, but lots of different pain medications, primarily opioids, by the way, stem from Germany, right? So there was the Colby Company over there in Germany, and they were the first to mass produce salicylic acid. So, we're not talking willow trees anymore. A couple more centuries later, 1870s, a scientists as a group, collectively over centuries, demonstrated that aspirin could successfully treat rheumatoid arthritis, rheumatic fever, and gout. So we're getting somewhere with, the proof along the way here. And it took a while, but the first FDA approval for an NSAID was indomethacin in 1965. My, how far we've come. There's a lot now, right? So that next decade in the 70s, that's when I believe it was John Vane discovered prostaglandin synthesis. The cascade, the inhibition of that is where it's at. That's the room where it happens. There's many rooms in the human body for NSAIDs as far as a mechanism of action. Okay, it's getting really granular, I know, but hey, the guy got a 1982 Nobel Prize, so there's that. That really sparked the NSAID renaissance, if you will. From 1976 to 1991, there was 15 different NSAIDs approved. That's a lot of medications within the same class, right? And the next decade, I'd say in the 80s, the big thing was COX-2 enzyme was discovered at BYU, 1988. And then in 1999, almost turn of the century, so close, right? We're all worried about Y2K. Well, right before that, we got celecoxib and rofecoxib. Oh my gosh, he said rofecoxib? I thought that wasn't on the market anymore. Yep, as of 2004, it was pulled off the market. Call it knee-jerk, call it important, call it safety concerns. We got it all going on there. When Vioxx was taken off the market, it came into play, let's whittle it down. It really comes down to how the heck the medications work, right? Particularly as pharmacists anyway, us guys and gals, we always concentrate on how does it work and how much to ultimately lead to safety and efficacy, right? So let's dive deeper into that whole mechanism thing, right? That lands us into the arachidonic acid cascade. Picture a flow chart. Like when you call like a service provider and you want to complain about the cost or the service and they're like yes or no, or dare I say, folks, brace yourself, bad word, potty mouth coming, a prior auth. When encountering with those situations of consternation, there's flow charts on the other end of, okay, well, if this is the case, yes, you go here, you go there. It's like an extrapolation from what middle schoolers are reading with the Determine Your Own Fates books that are out there, right? The chapter books. Anyways, back into the arachidonic acid cascade. You start with a bunch of phospholipid membranes and phospholipase enzymes. And by the way, that's where corticosteroids are going to work. That's a whole nother topic. Maybe another Pain Pod episode someday, but here we're to talk about NSAIDs. You end up with arachidonic acid, and then you have other enzymes like COX-1 and COX-2, lipoxygenase. That's going to lead to leukotrienes along the way. But that COX-1 and COX-2, that's where it's at. That's the rooms where it happens. Thank you, Hamilton, along the way for where NSAIDs are working, right? They're blocking those enzymes. Those enzymes take arachidonic acid and, for the sake of conversation, make prostaglandins, other things like thromboxanes, prostacyclin, you name it. And those do things in our body, sometimes good, sometimes bad. It just depends. But that cascade, that flow chart is inhibited by NSAIDs, right? And if you're looking throughout the body, that's happening and affecting things like our GI tract, our GI mucosa, particularly, along the way with prostaglandin 2. Also in the kidneys, COX-1 and COX-2 for prostaglandin, different versions of them basically. And then in the cardiovascular system, also COX-1 and COX-2 come into play with things like platelets along the way, aggregation of thereof. But NSAIDs are blocking all of those actions. So to whittle it down, where our concerns come is, to be or not to be, that is the question. This is no Shakespeare here, but COX-1 or COX-2, selectivity, that's the question, okay? If an NSAID is selective a little bit more to inhibiting COX-1 as compared to COX-2, you're going to get a little bit more of the inhibiting the production of thromboxane. So a little bit less cardio issues overall. But the selective COX-1 inhibitors are going to affect the GI mucosa, so that could lead to potential additional ulcers and bleeding. So that's not good for the old tummy tract, right? Exact opposite for those NSAIDs that are more selective to inhibiting COX-2. It's usually a little bit more specific to the prostaglandins, like I alluded to earlier, so less GI issues, but also inhibits the production of prostacyclin, so there's going to be more cardio concerns overall. So it's, which one out of the way. So when you're talking about NSAIDs, COX-1 inhibitors, relatively happy heart, not too happy tummy. COX-2 inhibitors, relatively not so happy heart, but happier tummy along the way. I hope you could picture like the cartoons in your head there, right? That being said, though, when we whittle it down to the actual NSAID products, the medications, it doesn't end there. Get this, folks. There's different studies out there that show slightly different things. Have we been there before? Yes. Every day that ends in Y. There's so many different studies out there. There's 1 to 3,000 for every viewpoint out there. But the point being, what I want to drive home when it comes to NSAIDs for COX selectivity is they're all in the same ballpark. But the different studies, the different publications that are out there illustrating COX-1 selectivity relative to COX-2 selectivity for NSAIDs, because again, that's going to factor in on the cardio side and the GI side, amongst other things. There's differences here and there along the way. But the heavy hitters that are the extremes closer to COX-1 selectivity compared to COX-2, that part doesn't really change along the way. Then you factor in things like, oh, well, some of these are even OTC. Whoa, good golly, we'll get there. But, what do we do? What do we do, to help our patients along the way? So there's, I'll include stuff in the show notes, of course, but, when you have GI and cardio risks, NSAID selection comes up as a big thing, right? So if a patient has low GI and low cardiovascular risk, celecoxib is typically one that kind of rises to the top for selection overall. That's also within the AGS-Beers criteria as well as the one that's preferred overall for older patients, 65 and older. And then, conversely, if a patient has high risk for both GI and CV, cardio side, the idea is just to avoid NSAIDs because that's just too much going on, okay? In the middle, you could have low, moderate, or high risk for either or, and that's where it gets really foggy really quick. There's the idea of adding on something like a PPI, to protect the stomach along the way as well, too. But I touched on this like a couple seconds ago. Celecoxib seems to be, it's a more COX-2 selective NSAID, seems to be like the one that gets highlighted all the time. So why is that puppy not OTC yet ibuprofen and naproxen are? Whittle us that one, right? Well, we all know it's a timing thing of when things came out and this and that. And, the landscape changes overall for, FDA approval for OTC compared to prescription and what's going on at the time and all that. But yeah, it's food for thought, particularly considering the AGS-Beers criteria heavily favors celecoxib for our older patients in general before you start considering other conditions and drug interactions along the way as well, too, in general. All right, so NSAIDs, they be everywhere, right? They're actually in a lot of different pain management guidelines that are out there, and very oftentimes they're first-line treatment options, okay? I had to write this one down because I want to rattle off for all y'all, but when you look at pain management guidelines, okay, the treatment guidelines, NSAIDs appear as first-line treatment options for endometriosis, psoriatic arthritis, gout, polymyositis, tendonitis, bursitis, Paget's disease, reactive arthritis, axial spondyloarthropathy, diffuse idiopathic skeletal hypertosis, inflammatory bowel disease, and Kawasaki disease. Okay, that's like, that's a lot, right? So the point is, they're recommended and they're out there, but like every medication, they come with their baggage. You've heard that before from here. There's things that we have to take into account. By golly, part of the overall diverse pain management treatment plan could often and will often involve our interventional specialists and procedures along the way, right? Turns out there's times, for bleeding risk, of course, that patients have to discontinue their medicines, oftentimes NSAIDs for bleeding risk, before and, kind of after for, how long do you wait to resume them for those procedures. There's a lot of good references out there for that, particularly from ACIP for the international perspective along the way as well. But it's usually half-life driven, so how long the medicine's going to be in the body tells you how long you need to keep it out of the body, right, for the processing overall. So that at the point of procedure, there's nothing there. It's a really important big thing to keep in mind because we have diverse pain management treatment plans out there, right? On top of that, there's, of course, what medication doesn't have drug-drug interactions that are potentially of clinical concern, right? One that comes up always like, oh, aspirin and NSAIDs. Well, aspirin is an NSAID. It's like, good golly, let the guy into the family reunion. Turns out he started it. Ay. Anyways, I digress. Hey, we went over history before, right? Other medicines that come up, particularly something that could be relevant to pain management, SSRIs, SNRIs. right? We got the, serotonin factors in there as far as bleed risk in the background, selectively, typically 5-HT2, but that's going a little bit deeper. Other medicines, I've mentioned corticosteroids earlier. Spironolactone actually comes up as well, kind of randomly. One big heavy hitter, though, and this is important, folks. Luckily, the mitigation of it is typically pretty straightforward, but there's what I'd call the NSAID-inspired kidney punch. Okay, so NSAIDs are typically have the potential to decrease GFR, glomerular filtration rate, to the kidneys in the afferent arteriole. So what leads to the kidney? Whereas ACEs and ARBs, they're going to do the same, but right after the kidney, the efferent arteriole. So it's like a 1-2 punch before and after, where if an NSAID is utilized with an ACE or an ARB, there's a point of concern there. Luckily, typically it's just to monitor things like blood pressure, potassium, watch for edema, things like that. Things we're going to typically do anyway, but we want to have that heightened alert along the way there. That's just one of those drug-drug interactions we wanted to point out. There's certainly going to be others. When you look into the CYP450, the hepatic system, the liver, 2C9 comes into play. And, that's a heavy hitter for NSAIDs. A lot of the NSAIDs are actually substrates for CYP450, 2C9. I know you knew that, but, just a reminder. We have our moderate inhibitors there for 2C9, things like carbamazepine or Rifampin, you name it. There's other minor ones. As far as inhibitors, major one would be fluconazole, and that could be a one-off prescription oftentimes, so we've got to watch for that one. So on and so forth along the way. But the bigger picture question is not only with drug interactions, but then also with pharmacogenetic considerations, this whole 2C9 thing, right? So you've got folks like celecoxib, ibuprofen, indomethacin, piroxicam, you name it, being metabolized by CYP450, 2C9. In fact, like diclofenac, meloxicam, naproxen, they're there as well with additional other CYP450 enzymes as well. But then we got to think about which NSAIDs, if there's a concern with 2C9, whether it's pharmacogenetics, whether it's a drug-drug interaction, you name it, which ones aren't in that boat, right? So you have your non-CYP450 prodrugs, that would be Sulindac and Nabimetone, and then just additionally the other non-CYP450 NSAIDs for metabolism, respectively, Ketorolac. Oh, you heard Pain Guy with that one before on the old kidney stone episode, right? Check it out if you haven't. Watch it a fifth time if you have. But anyways, Ketorolac, Etodolac, ketoprofen, and oxyprofen, right? That's the 4 in that gang, really a half a dozen when you include the prodrugs. But those are options overall when it hits the fan as far as drug-drug interactions and pharmacogenetic considerations along the way. As far as, I touched on NSAIDs being within guidelines. There's also, the concept of FDA approvals, like what are they approved for? Oh, a lot. Osteoarthritis, rheumatoid arthritis, ankylosing spondylitis, like, acute pain comes to mind, right? Primary dysmenorrhea, gout, sometimes in some instances, migraine, fever, bursitis, tendinitis, you name it, along the way. It's really just which one has what approval. And if you're interested in that, we just double check, of course. So how do we distinguish NSAIDs other than, what they're used for? That's another bigger picture. All right, put the old medchem hat on, right? Structures, baby. We did this with opioids on that episode back in the day, but there's different structural classes of NSAIDs, just, the ones that look similar. It's the families along the way. Things like acetic acids, phenamates, oxycams, propionic acids, diaryl heterocycles, or the COX-2 selective, basically celecoxib, naphthyl alkalones, nabimetone, and then the salicylates, they could be either acetylated or non-acetylated. See a lot of OTCs there in that group, but I'm just rattling through them because it's structural classes, folks. It's not something for a billboard, but I'll use that organization to let's jump through a couple of them. Like, what's some notable things? Not necessarily clinical pearls, but notable things. Like notable side effects. So, for instance, like Etodolac. There's a notable potential side effect, like 10% of the time in the literature, even package insert, dyspepsia or indigestion. What's some other little things here? Indomethacin. So, that was the first FDA approved non-aspirin NSAID back in 1965. Mentioned that earlier. Very comparable to aspirin when it's GI upset, but typically a reduced pill burden or acid load. Let's see, what else in the acetic acids? You got Solandac, that's actually a prodrug, so it's going to be activated by the body when it's metabolized, typically a little bit less GI upset. John, what was the next class? Heteroral. Ketorolac, everybody knows this one. It's probably on every exam out there. Do not use for more than 5 days. The GI, heart, kidneys, everybody's in a flare. Let's see. Tolmetin, another one within that structural class, got a relatively small, notable potential side effect of nervousness. I mean, that kind of stands out when you're talking NSAIDs, right? Diclofenac, we got a lot of topical products. We'll get there in a hot second. But as far as even oral ingestion utilization, edema. So edema could be a side effect, kind of counterintuitive. And it's in the books as about a third of the time. So got to watch for that all along the way. All right, so diclofenac, it's got so many different formulations. Oh my goodness, patches, gels, powders, solutions, capsules, tablets, powder. You could use it for oral solutions, ophthalmic solutions, injections, you name it. I think I named them all. I don't know. And even in the oral formulations, we have the enteric-coated tablets. That was back in the 80s. Then the XR tablets in the 90s. Then the capsules for 4 times a day in the early 2000s. And then about a decade ago, 2015, we got the Solumatric capsules along the way. A lot going on in variety, right? One of the things I mentioned, though, and this kind of kicks back to another Pain Pod episode as far as topical pain medications, but let's touch on some of those because there's an appreciable amount out there. Again, transdermal, you apply it here, it works over there. Topical, you apply it here, it works here. Hopefully you can visualize that along the way, right? But our topical NSAIDs, it's winner, chicken dinner, diclofenac, okay? Got lots of different options, but it's diclofenac in the end, okay? You've got patches. There's 2. There's the twice daily Flector and the once daily Leichhardt. There's also solution, liquid, we'll say, the diclofenac solution. That's Pennsaid. Funky fact with that one. Good golly. So it's a topical solution that can have a potential side effect of garlic breath. Say what? Yeah. So the formulate, the product, the medication includes DMSO, okay? And that is actually metabolized in the body to dimethyl sulfide. And yeah, the sulfide, that's what gives it that quote-unquote garlic breath side effect if it's, excreted in the lungs and skin along the way. All right, back into topical NSAIDs, diclofenac. We also have, of course, diclofenac gel. That was OTC in our country. I'm sorry, was prescription, then became OTC. It is OTC and prescription now. I call that the love story. I remember the missus and I, when we were on our honeymoon at the resort, went to the gift shop. Yeah, you were wondering where that was going to go, right? We went to the gift shop, and there it is, staring at me. Topical diclofenac over the counter back in the day. And I'm like, you got to be kidding me. They have it here in the island in the middle of nowhere. Yet we don't have that back home. Fast forward to Valentine's Day 2020. That's when topical diclofenac gel was approved in our country for OTC status. What a love story. Good golly. So, topical diclofenac gel, it's said to take up to a week for efficacy. Got reports otherwise, of course. It's intended for osteoarthritis, joint pain, hands, knees, feet. It is stated to have not been shown effective for strains, sprains, bruises, sports injuries, things like that. But then, of course, there's phase 4 utilization out there. Now, when I mention hands, knees, feet, eyes, fingers, knees, and toes, right? What about the dosage? It's all about the dosage, baby, always, right? So 2 at the top, 4 down below. If it's, the hands along the way, that's up top, do the touchdown pose, that would be 2 grams of the product. Knees, feet, they're down lower. It's larger joints. That's 4 grams, okay? That's all for naught if you don't have a dosage guide. So we could always remind patients or remind our friends that dosing cards are available online. Once you do it once or twice, patient gets used to how much is actually needed along the way. Okay, hopefully that helps. All right, that's that for diclofenac for now. Let's jump to another class. I was saying I was going by structural class, the phenamates. Meclofenamate. So that actually inhibits prostaglandins and leukotrienes. The rest of the gang of NSAIDs does not have that leukotriene inhibition there. So, maybe that could be better for a patient with asthma per se, or, the whole seasonal allergy asthma scenario there. Debatable there. What else we got? Mefenamic acid. There's actually a notable side effect with that. Not common, of course, but premature closure of the ductus arteriosus. Well, that's very unique and specific, right? Onward we go. Good golly, the Oxycam. So meloxicam and peroxicam, you get once daily dosing. That can help folks if that's desired. The peroxicam, by the way, has a notable potential side effect of a higher rate of relative NSAID skin reactions. So, random unfun fact. All right, let's go to the propionic acids. Phenoprofen. A lot of times it's observed for acute and post-op pain, even dysmenorrhea. Florbuprofen, what would be a pro there? So taken with food is actually going to decrease the absorption, to my knowledge, and the GI side effects along the way. Ketoprofen that one was actually OTC. It was coated tablets, but that was changed to prescription. So, opposite of that whole topical diclofenac scenario. Oxyprosin has a relatively unique, the acute therapy starts with up to 3 tablets as the loading dose. Also, when you see ox, lay public may assume an opioid. Obviously, false, like Dwight would say on The Office, right? Hey, I'm from Scranton. How could I not talk about the Electric City, folks? Anyways, we're talking OTC. So ibuprofen products, there's a plethora of them over the counter, of course. You have a lot of the OTCs, like the junior products, the regular, can be combined with acetaminophen. You know what? I'll touch on that later. You got infant drops, you got suspensions. Prescription-wise, you have the tablets, of course. There's also the Duexis, the combination with famotidine along the way as well. Now into that OTC ibuprofen. So over the counter, whether it's acetaminophen, that's how you say it, right? Whether it's acetaminophen, I know, or ibuprofen, the pediatric dosing, oh boy, that's something to drive parents nuts, right? So when you look at the label, it's like, oh, well, talk to a doctor, talk to a pharmacist, talk to somebody, but the answer's not on the label. For younger or lighter, less weight, earlier age patients. So we're talking about NSAIDs, so I'll concentrate on ibuprofen here, at least try to. When a baby's 6 to 11 pounds and or the age of 0 to 5 months, it's a do not use, right? So basically a child has to be at least 6 months old and 12 pounds to utilize ibuprofen overall. And you're starting there typically at about 50 milligrams. It's been said, this is never medical advice along the way, but in the big picture, when you're talking about fevers, if it's, lower grade, less than 102.5, I believe, you're looking at about 5 milligrams per kg. If it's at that or above that, you're looking at about 10 milligrams per kg for ibuprofen. But again, that's has to be worked into the patient scenario as well, too. So, all right, let's jump out of that dose there of ibuprofen and jump further down in the aisle, OTC naproxen. That was first marketed back in 1976. Yeah, right when the first Rocky movie came out. I'm sure that's related, right? Correlation, not causation. That's one of the naproxen, one of the 2C9 substrates. OTC is approved for those over 12 years old, so past Little League age. Prescription is for those more than 2 years old, so the whole gang playing baseball. All right, what about we have also the celecoxib, kind of a group of its own, of course, known for its COX-2 selectivity. We banged that drum earlier. Nabumetone, if you want to say it that way, it's a prodrug, relatively less GI side effects, has once daily dosing with or without food, so that could be helpful for patients too. All right, that leads us down the path, towards the end there, the salicylates. So acetylated ones would be aspirin. So where's that name come from? So acetyl, take that A, spirin, take that whole name. That's aspirin, from the Spiraea ulmara plant. It's also known as meadowsweet. It's natural, right? It was also first synthesized, aspirin that is, back in 1897. A couple years later, Bayer introduced it for medical use. Along the way, we touched on some of the other history earlier, but notable side effect, of course, is one of the concerns with Reye syndrome. before I touch on that, of course, there's the products that are out there. OTC, of course, we have the infamous quote unquote baby aspirin. Hey, not for use in children. But we also have formulations of like rectal suppositories and enteric-coated things, the chewing gum, you name it along the way. But Rye syndrome, I want to touch on that very briefly. So Dr. Douglas Rye was the one to first publish a description in the Lancet back in 1963. So it's been a while. Rye syndrome, it's basically an acute non-inflammatory encephalopathy with fatty degenerative liver failure along the way. It typically occurs after viral illness, when aspirin's utilized, by the way. Early on, a patients can experience typically diarrhea, rapid breathing, that's a notable one, vomiting, severe fatigue, you name it. All children with these symptoms should be tested for IEEM, inborn errors of metabolism. Okay, it's basically genetic concerns along the way. For Rye syndrome, there's no specific treatment beyond supportive care and aggressive monitoring. So got to keep that in mind. It's all about preventing in the first place. Oh, that little quote unquote baby aspirin, right? Oh, here's another one that comes up when you're talking baby aspirin. So what if someone's utilizing, whether the guidelines recommend or not, if a patient's utilizing cardioprotective aspirin 81, should they take that before or after or at the same time as their NSAID for their, let's say, osteoarthritis? Well, it gets tricky. Typically, and here's how I look at it, patient-centric. Patients probably going to want to take their pain medicine first. So if you take the pain medicine NSAID, you typically want to recommend to wait 4 hours to take that aspirin later on in the day. Okay. Or if they take the aspirin first, wait at least 2 hours to take the NSAID. In general, the NSAID that was for pain, not the aspirin itself. Okay. Hopefully that makes sense along the way. Still, the OTCs, we have those salicylates, the non-acetylated ones, choline salicylate, magnesium salicylate tetrahydrate. There's choline, magnesium, trisalicylate, if I'm getting that one right, diflunaso, salicylate, you name it. The whole gang's there. There's a lot going on with those, of course, because they're out in the OTC aisles. Free reign for folks. They're even in things like cold combinations, numbing gels, earwax removal. That's the choline salicylate, by the way, along the way there. So really important to keep that in mind overall. Also, jumping far from the OTC aisle, there's injectable NSAIDs. Let's not forget our friends that are injectables, like ketorolac. Ibuprofen's also available, and then meloxicam as well. As far as the latter being IV, forgot to mention that along the way, but ketorolac, IM, IV, ibuprofen, meloxicam, IV. So those are available along the way there, okay? Speaking of availability, by the way, we usually talk about what's available in our country here in America, but when you cross the pond in any direction or take a drive, different countries have different names oftentimes for medications. For instance, in Italy, the mother country, back where the Garofoli Vineyard is on the eastern side, back of the boot along the Adriatic. Anyways, in Italy, Flomax is actually an NSAID. Who knew? Well, an entire country. In Israel, Cartia is actually aspirin. That's just two examples in the NSAID realm here overall, right? But folks, big picture, kind of the biggest part here, getting towards wrapping up, I guess, but really the important part though is what I'd say the NSAID baker's dozen. Okay, it's really important and great to consider everything that we talked about so far in this episode when it comes to NSAIDs. But now what? How do you select an NSAID for the most appropriate, safe, and effective utilization for a patient, particularly a patient in pain? So some factors that I'd say would be, NSAID selection factors here, okay? Baker's dozen, meaning 13. Is it acute or chronic pain? Address that. What is the medical condition or situation? Perhaps there's guidelines to guide us along the way, right? Couple patient-centric things along the way, really important. Is there a formulation preference? Would somebody prefer to have topical or oral, so on and so forth? Obviously, want to talk through any cardio or GI concerns. Along the way with pulmonary concerns, perhaps. Remember that meclofenamate, the whole leukotriene situation? Then, of course, renal and hepatic impairment as well, if that's a factor, or just their function overall. Jumping back to like patient-centric things, like what's the dosage frequency? Does somebody just want to, one a day, set it and forget it, like a rotisserie chicken 30 years ago? Rompopil, I know. Or patient being more active in their pain management. Want to take things multiple times a day. It could be a preference. I mentioned very briefly if there's any interventional procedures, there may be a need to discontinue the NSAID for a short period of time before and hold off on resuming. So the less that the time of discontinuation is, the better. I mean, for instance, you don't want to have to stop something like for a whole week. That's a week without the pain medicine for a procedure that's going to be hopefully helping with pain in the end. Got to check out another one of the baker's dozen would be the drug-drug interactions. And then also, does somebody prefer OTC or prescription, or is that in the realm of concerns? Right alongside that would be cost concerns. That would be, I'd say, number 11 probably. Probably should mention this even earlier, but age, is it a pediatric scenario, an older patient scenario, an adult patient scenario or not? And last but not least is the patient pregnant, because then that's going to be a no-go, right? So that's the proposed. I'll have these available, of course, on show notes. Maybe I'll even put them on painguy.us. We'll see, because all these episodes are available there, but we also want to provide some of this information visually along the way as well. So that's the NSAID selection factors, the old baker's dozen for NSAIDs in the background. Hope that helps lots of people. To wrap things up, though, okay, and this is both for clinician and patient and lay public alike, again, it's all about having a diverse pain management treatment plan overall. Typically never just one treatment option, right? That's where we start, but not necessarily where things end up. Ibuprofen and acetaminophen. I got that right? Okay. Ibuprofen and acetaminophen together have been shown, we're not talking huge astronomical studies along the way here, but now we do have combination products, so that paves the way. But, when you combine ibuprofen and I'll say paracetamol, it gets to be comparable, if not better, than some other pain medicine combinations that even involve opioids. So think about that, right? That could really help our patients. And by the way, you're talking about things that are available both prescription and over the counter. So I just wanted to end on that of, really emphasizing that even though we're covering NSAIDs today on the Pain Pod, it's still important to have that diverse treatment plan overall. And by the way, not just pharmacological, non-pharmacological as well too. All right, folks, we went over a plethora of all things NSAIDs, right? And then hopefully we were able to talk our way through the NSAIDs Baker dozen, the NSAID selection factors overall, right? And then the emphasis on the overall combination of treatment options there as well, too. I truly, truly hope that this can help you in your practice or in your own care even. Again, not direct medical advice within online and whatnot, but these are factors that come into play to discuss amongst either with healthcare professionals or amongst healthcare professionals as well to really get the best pain management treatment overall. So Pain Pod Nation, I hope you enjoyed this all things NSAIDs episode, and I certainly welcome you back to the Pain Pod in the future. I hope you have a great day every day.
If you'd like to join Mark on the Pain Pod, send us an email to publisher at pharmacypodcast.com. And make sure to share the show and subscribe on your favorite podcast directory. Thanks for listening.